Now we move on to the next technical session. It is on approach to Madhumegam. To deliver on this topic, I request Dr. Eugene Wilson, Research Officer Siddha, Central Council for Research in Siddha, to kindly be on the dais. Please, sir. Before going to the topic, I would like to give a very brief intro about our speaker, Dr. Eugene Wilson. Dr. Eugene Wilson is working as a research officer Siddha in Central Council for Research in Siddha headquarters office, and he is also the organizing secretary of this 2 days colloquium. Sir has completed his BSMS from Government Siddha Medical College, Palayangotai, and his specialization is in Podu Maruthuvam, MD Podu Maruthuvam. To say about his research and academic experience, he has worked as assistant professor in Sai-Ram Siddha Medical College and Research Center, and also served as lecturer in Shastra University. He has also worked for Health India Foundation, and he is a recipient of the 7th European Union Research Framework Program for 14 months. He has worked as a research fellow in University of Duisburg, Essen, Germany, and he has many publications and presentations to his credit. His research specialization is research pertaining to standardization, preclinical research, clinical research, and literary research. With this very brief intro, I now invite Dr. Eugene Wilson to deliver the lecture. Please, sir.
Thank you, Dr. Meena, for the kind words. At the outset, I would like to thank our Director General, Professor Dr. N.J. Muthukumar, for giving me this opportunity to present about my approach to Madhumegam, nothing but Mega Vada Nilai. So, the points which I would touch is mainly the main 4 points I want to highlight. That is, Siddha classification of Mega Noigal is horizontal, and as we are listening from day one, every patient is different and unique. So we should have a individualized approach for each patient. And as we know, Megano is not mere management of numbers. So reducing their blood sugar from 300 or 400 to 200 or normal is not sufficient. So average is not normal. So, and umbrella, meganoigal is an umbrella term which can affect everything importantly. In diabetes, we have this macrovascular complications and microvascular complications. So we know all about the, we commonly say nephropathy, neuropathy, retinopathy. Above that, we have this microangiopathy and macroangiopathy, where we have the vascular complications are more and it is more fatal and alarming. So we all know about the classification of meganoi as 20 in number. So we also know about the term pyramegam or premiamegam. So it is just to distinguish, it is other than madhumegam. So in the text Megavaga Theret, it has been clearly mentioned that it is the non-diabetic cause, that is secondary cause is premiegam or premiamegam. On the other hand, primary megam is madhumegam, which is mentioned under adult category. So the why this horizontal approach in Siddha given by our Siddhas is that integrates prevention and care within a broader approach, including other NCDs such as mental disorders, and we can use it as a primary healthcare model. And as we see in the article, personalized medicine for diabetes is the focus. So there are many factors and relationship affecting drug response. So each patient responds to a drug differently. So we have the genomic phenotype, molecular and cellular phenotype, clinical phenotype, molecules, alleles, individuals, drug response, and also the environmental factors play a role. So coming to the third important point, not mere management of numbers. So the Research Society for Study of Diabetes in India, uh, and according to that expert panel, suggests that HbA1c cannot be used as a sole measurement for diagnosis of diabetes in Indian settings. So it is always used, not always, with a caution, because we have that influence of iron deficiency anemia on hemoglobin A1c levels in diabetic individuals with controlled plasma glucose levels. So in anemic patients, the A1c levels would be uh, on the higher side. So that the article which I've quoted mentions that the study found a positive correlation between iron deficiency anemia and increased A1c levels, especially in controlled diabetic women and individuals having fasting plasma glucose between 100 to 126. Therefore, what we is important is before we alter the treatment regimen for diabetic patients, presence of iron deficiency anemia should be considered. So that is the key point. So often we go by HbA1c levels. So whenever a patient walks in, we ask for HbA1c levels, and we think that when it is higher, especially to the human folk, we should be careful in modulating the treatment. Another area where we can miss a real important diagnosis is euglycemic diabetic ketoacidosis. Euglycemic means when the blood sugar levels are normal. Can be a misdiagnosis in an emergency department with worse outcomes. So, diabetic ketoacidosis is often not associated with high blood glucose levels, as we tend to think that if a patient is having more than 400 or 500 blood sugar levels, he is more prone to develop diabetic ketoacidosis. That is not the case. So many don't realize that they become ill from ketoacidosis when the blood sugar level is under 240. So even less than 250 or 240, a patient can develop a diabetic ketoacidosis versus 400 milligram, normal in the sense that they are without diabetic ketoacidosis. So diabetic ketoacidosis in patients with lower sugar levels occur when there is enough insulin in the body to prevent the breakdown of fats. Although cases of euglycemic diabetic ketoacidosis have occurred in people with type 1 and type 2 diabetes mellitus, type 1 patients are at higher risk for diabetic ketoacidosis than type 2 patients. So other causes of euglycemic diabetic ketoacidosis include pregnancy, fasting, bariatric surgery, gastroparesis, insulin pump failure, cocaine intoxication, chronic liver disease, and glycogen storage disease. And even after this problem is worse after the introduction of sodium glucose co-transcriptase, and emergency rooms have seen an increase in the cases of euglycemic diabetic ketoacidosis. So current estimates peg at 2.6 to 3.2 of all diabetic ketoacidosis cases, though the percentage might be low due to underreporting. So that is an important point to note. So see, there's an article where it's always a misdiagnosis. We often tend to miss it. So euglycemic diabetic ketosis is a diagnosis of exclusion and should be considered in the differential diagnosis of a sick patient with a history of diabetes mellitus despite lower blood glucose or absent urine ketones. So how should we work up? Includes arterial blood gas as an important parameter for metabolic acidosis, serum ketones, and exclusion of other causes of high anion gap metabolic acidosis. So this is another article where we the experience of 44 patients with and comparison to hyperglycemic diabetic ketoacidosis, where they compared both euglycemic patients and hyperglycemic patients. Another thing is the vascular complications. So not always we know how the patients react. So every patient is individualized. So we tend to miss the microvascular or vascular complications. So as we all know, the prevalence of diabetes is very high, and we are known as a diabetic capital. And we have the percentage that is uncontrolled. Many individuals are undiagnosed. See, approximately 50%, 57% of the individuals remain undiagnosed in a country like India. And uncontrolled diabetic mellitus leads to increased risk of vascular disease. And much of the burden of type 2 diabetes is caused by macrovascular, that is cardiovascular, cerebrovascular, and peripheral artery disease, and microvascular, as we already know these complications. So what should be the outcome of the treatment? I told we should not rather mind the numbers. So that should also be there, but our focus should not always be there on the numbers. We should reduce the disease burden. In a country like India, we have the burden of the disease is too much that all the markers, wherever the health indices is being is paying spoil sport by diabetes mellitus. And we have to remove the diabetic feel of the patient. So whenever a patient has diabetes, he tends to have this diabetic feel. So our focus should try to remove the diabetic feel from the patient, and as well as one thing comes to my mind, that is the diabetic patient will always complain about fatigue as well as fear. So many patients we come across, we have only symptom as they will say as fear. And we have to address that. To remove the diabetic feel, we should focus our treatment and to improve the quality of life. So we know that hermeneutics and our approach to diabetes, from where we have transformed our ancient wisdom. See, in all that 20 types of classification of diabetes, they have categorized these 20 based on the smell or even taste. So everything ends with mananeer, mananeer, mananeer. So see the end without even having the sophisticated instruments, our Siddhas stand tall in diagnosing the disease. So this is the Madhumegam which we are talking about. Tanmiyai salandanam pasappu manjal, தானிரங்கும் பீசமும் கோசமும் கடுக்கும் அண்மையாய் அடிக்கடிக்கு நீரிறங்கும் மடிக்கடிக்கு அரைநாள் தனிலே காணும் வெண்மையான தடி தனித்தான் பிடிக்கும் மிக்கான சடம் விழுத்து மேனி கன்றும் பன்மையாய் பஞ்ச வர்ண அதில் கொள்ளும் பகர்கின்ற மதுமேகத்தின் பாங்குதானே. So the Yugi classification stands tall pertaining to diabetes, and it comes under the Aral type of Madhumegam. So Megavada Nilai, it denotes the commonly known 10 types of avatais we study. So the extreme agony the patient faces is denoted as Megavada Nilai or avataigal. So these are the 10 types. We will try to quickly focus the time we have. So the first one is describes about நோய் தோன்றுவதற்கு முதல் குறியாக உடல் பருத்து கொண்டே வரும் நீர்ப்புழை அகன்று வரும். See, the pre-diabetes has been long been foretold by our Siddhas. So it's a high risk state for the development of diabetes and its associated complications. And among individuals within a healthy BMI, the prevalence of pre-diabetes and abdominal obesity has substantially increased. So everything has been substantiated with the research articles which I have given in the footnote. So you can refer it at a later stage. So this was that how the pre-diabetes was categorized or grouped. So in 1997 and 2003, a group of individuals whose glucose levels did not meet the criteria of diabetes, but were too high to be considered normal, were recognized by the expert committee on diagnosis and classification of diabetes mellitus. So pre-diabetes was defined as impaired fasting glucose, that is from 100 to 125, or impaired glucose tolerance after OGTT of 140 to 199. See, we have this bladder dysfunction where நீர் புகை அகன்று வரும். So the urethra undergoes morphometric and functional changes in both myogenic and neurogenic components. So how the wisdom of Siddha stand tall, even that the changes which the urethra undergo has been documented. And in bladder dysfunction, we also see glucosuria and osmotic diuresis both lead to increased bladder stretch, elevated intravesical pressure, leading to bladder hypertrophy. And in lichen sclerosis, it's a chronically relapsing disease with a potential for atrophy, destructive scarring, functional impairment, and malignant evolution. So it's a chronic inflammatory skin disease with a distinct predilection for anorectal region. And we always talk about polyuria, especially nocturnal polyuria. So I skip this. And many patients with fungal infection come to us. So that is the starting point of diagnosing their diabetes episode. So always consider the possibility of underlying diabetes in cases of candidal balanitis and vulvovaginitis in women, particularly in middle-aged and overweight patients. So fissuring along with balanopostosis was found to be more common in sexually active males. So presenting symptom of diabetes may also be a cause of poorly controlled diabetes. So this could be a presenting symptom. As well as in vaginitis, so it's a commonly encountered comorbid condition of diabetes, and it is also linked to poor glycemic control. So many patients are diagnosed to have diabetes when they are present with symptoms of vulvovaginitis. So others experience episode of uncontrolled or refractory hyperglycemia, which can be attributed to untreated vulvovaginitis. And one could also experience perivaginal abscess. So kanada talam, so it indicates vagina. And mega kattiyadu kadithu vedithu ranamame. So the descriptions are very peculiar, clear cut, describing these classical conditions. So another changes, we have lot of skin changes in diabetes patients. So skin disorders will be present in 79.2% of the people with diabetes. So the common is acanthosis nigrans. So it occurs in 74% of obese adult patients. So the lesions I've documented. This is diabetic dermopathy, eruptive xanthoma, rubiosis facie. So conditions associated with type 1 diabetes, we have this necrobiosis lipoidica. So it has, the features have been clearly mentioned as Odukarapan, and we also have an apt treatment mentioned that is Padriver Kashayam. So these are some of the conditions which are clearly documented in our text. So this is tense bulle. Yesterday we heard from Ramesh sir. And this bullosis diabeticum or diabetic bulle is also seen in patients with type 1 diabetes. And the third, அவத்தை we see வரட்சியுடன் வயிற்றுள் காற்று கூடி பெருகும். So polydipsia we know, and we have this diabetic gastroparesis, where we have this postprandial discomfort and bloating. Since I will be sharing the slides, I am skipping some due to want of time. So fourth one is diabetic ketoacidosis. We have seen that earlier, my pre-slides. So fifth one is diabetic cystopathy. So சிறுநீர் பெருகி இழிந்து விந்து நட்டம் உண்டாம். So we have this classic symptoms: decreased bladder sensation, increased bladder capacity, and impaired bladder emptying, with the resultant increased post-void residual volume. So voiding dysfunction is there, urinary retention, and recent clinical evidence indicates the presence of storage symptoms such as overactive bladder. So many patients complain that, and one major concern is also incontinence in women with prediabetes. So we have seen this, and coming to the sixth one, படுக்கையில் கிடக்க ஒட்டாத மூர்ச்சை உண்டாகும். So it can be correlated to restless legs syndrome, and we also see uremic type of encephalopathies. And seventh one is வாய் குமட்டி சுவை அற்று பெருமூச்சு உண்டாய் உடல் சோறும். So impaired taste is one of the key findings here. Where we have also see pneumomediastinum. So it's a rare complication of diabetic ketoacidosis, where we have Kussmaul's breathing. The respiratory compensation mechanism in metabolic acidosis increases the alveolar pressure above normal inspiratory pressures and predisposing to alveolar rupture. So fatigue, as I already told, it's a diabetic feel of the patient. So we have to, this is the mechanisms of fatigue. And உடலில் கடலை கட்டிகள் நீரில் பிளவை நிகர்பிளவை. So this song elaborates that the diabetic patients develop carbuncles. So see the appearance of the carbuncle. So ஒடுக்கம் தவறல், it can be equated to ஏமம் தவறல். So it affects the quality of life. That's what I told in our aim of the treatment is to increase the quality of life of patients. And பெருங்கழிச்சல், it indicates diabetic diverticulitis, and pulluceral, it indicates maggots. So we should, the definition of quality of life as per WHO. See, we in diabetic diverticulitis we have this kadichal diarrhea. Maggots, diabetic foot ulcer. See the classic in our senior teacher who has also treated this condition. So coming to the end, இளைப்பு நோய் உண்டாய் நோயினை கொல்லும். So our Yugi Mamuni describes the symptoms of patient with meganoigal, which progress from obesity to impotence, thirst and glycosuria, and ultimately to unconsciousness or tuberculosis. So it is mentioned in the journal. So we know this is the research criteria, how we diagnose the disease, that is more important. And since in every patient that walks to the clinic, we should try to rule out diabetes. So that is our main role. Since the burden of the disease is very high, every patient who walks into our clinic, we should be certain that we rule out diabetes. And our books mention that Kudila Nadi, we can see the exact pattern Kudila Nadi in pre-diabetes patients. So this studying the levels of evidence which we focus from level of evidence A, B, C and E, and this is the Indian diabetes risk score where we can assess the patients and we can treat effectively. So we also know that we have only type 1 and type 2 diabetes, but we have one more type, that is type 1.5 diabetes mellitus. It is called as latent autoimmune diabetes of adults. It's a form of diabetes which features both features of type 1 diabetes and type 2 diabetes and is termed as type 1.5. So the synonym is slowly progressive insulin dependent type 1 diabetes mellitus. So the WHO also defines LADA as slowly evolving immune related diabetes. So the definition criteria is given. So the age is greater than 30 years, positive antibodies to islet beta cells, and insulin independence for at least the initial 6 months after initial diagnosis. So most of these patients present with hyperglycemia that is not as dramatic as type 1 diabetes mellitus and is misdiagnosed and manages as type 2 diabetes. So that's what the entire 2 days program is. Diabetes is the key or main take home message that you take on. So try to evolve your own diagnosis pattern before starting the treatment. So before giving treatment, focus on diagnosing the disease rather than treating the disease. We all are prone to write our drugs very keenly, and we also repeat it. So in our everyday OPDs, we write many drugs and we repeat the same to the patients. But let us from now onwards focus on. So type 1 is clearly mentioned as Nirgana Mandam, and so we are moving to case studies after lunch, and it will be dealt by Dr. Balamurugan. Thank you.
Thank you, Dr. Eugene.
AUX mode.
Any questions? Students?
ஒரே ஒரு கொஷின் தான் நான் பேச போதில் அதில். டைப் 1 டயபெட்டிஸ் நம்மக்கிட்ட வராதுன்னு கிடையாது. நீர்கண மாந்தம்னு ஒரு டயக்னோசிஸ் பாலகடத்தில் இருக்குது. அதுக்கு சமமான நோயாடலில் உள்ள பாட்டு டைப் 1 டயபெட்டிஸ்க்கான பாட்டு இது அப்படி ஒன்று கிடையாது. ஏன்னா அது இன்சுலின் கண்டுபிடிக்க முடிய வரைக்கும் குழந்தைங்களுக்கு இருந்தோட சரி, அது சன்னி வந்து இறந்து தான் போயிருக்க வழி. அப்படி ஒரு கிளாசிஃபிகேஷன் ஒரு டெக்ஸ்ட்டில் கிடையாது. பட் இந்த லேட் ஆன்செட் டைப் 1.5 உண்டு. இதெல்லாம் விடுங்க. இவர் முக்கியமாக நீங்கள் தெரிஞ்சிக்க வேண்டியது, ரீசெண்டாக என்னுடைய ஜூனியர் ஒரு பையன் எனக்கு ஃபோன் பண்ணி, சார் ஒரு பேஷண்ட் வந்து டயபெட்டிஸ் பேஷண்ட் வந்தாங்க, நான் ஆவரை கொண்டேன் அவள் சில மருந்துகள் கொடுக்க ஆரம்பித்தேன். கொஞ்ச நாளே எனக்கு அவங்களுக்கு வந்து விரல்லாம் வலிக்க ஆரம்பிச்சிருச்சு, 2 இடுப்பும் வலிக்க ஆரம்பிச்சிருச்சு, ஏவாஸ்க்கு நெக்ரோசிருச்சு, இந்த பக்கம் ஒரு மாதிரி மல்டிபிள் ஜாயின் போயிட்டு இருந்தது, ஏன் எல்லாம் பார்த்தெல்லாம் நார்மலாக தான் இருந்தது. நான் அதற்கும் மருந்து கொடுத்தேன், இதற்கும் மருந்து கொடுத்தேன். அவங்க போய் லோக்கல் ஒரு டாக்டர்கிட்ட போயிட்டு பெயின் கில்லர் சாப்பிட ஆரம்பித்தாங்க. 3 வாரம் 4 வாரம் இருக்கும். பார்த்தா எல்எஃப்டி ஆல்ட்ரா இருக்குது, பேஷண்ட் ஜாண்டிஸ் இருந்தது, எல்எஃப்டி ஆல்ட்ரா இருக்குது. அவர் பயம், நான் கொடுத்த மருந்தால் வந்துருமோன்னு இவங்களுக்கு பயம். ட்ரீட் பண்ண ஆர்த்தோபெடிக் சர்ஜனுக்கு அவர் மேலே பிளேம் வந்துடும் அவருக்கு பயம். இவர் முந்திக்கிட்டு என்கிட்ட ஃபோன் பண்ணி கேட்கும்போது நான் வந்து ஐ க்ளோஸ் மை ஐஸ். வாட்ஸ் ஃபஸ்ட்டு திங், பேஷண்ட்டுக்கு வந்து சுகர் இருந்தது. நான் டயபெட்டிக்காக இல்லை நான் மருந்து கொடுத்தாலும் வந்ததுன்னா பேஷண்ட் நீங்கள் சொல்கிறாங்க. ஸோ இவர் முதல்ல ஆரம்பித்தது ஃபிங்கர் பெயினுக்கு வந்து ஆர்த்தரைட்டிஸ் கொடுக்க ஆரம்பிச்சிருக்காரு. சுகருக்கு எனக்கு தெரியாது. ஐ ஹவ் நெவர் செக்டு டயபெட்டிக் அவரும் சொல்லலை, எனக்கு தெரியாது. அதில் பேஷண்ட் டயபெட்டிக்னு சொல்லணும்னா முதல்ல அவருக்கு தெரிஞ்சிருக்கும் இல்லையா? ஸோ முதல் கொஷின், டயபெட்டிக் நோன் டயபெட்டிக் ஆர் நாட் நோன் டயபெட்டிக். டயபெட்டிக்னா ஆல்ரெடி எஸ்டாப்ளிஷ் டயக்னோசிஸ். நாட் டயபெட்டிக்னா ஆல்ரெடி சுகர் பார்த்துருக்காங்க நார்மல், ஸோ நாட் டயபெட்டிக். நாட் நோன் டயபெட்டிக் இது வரைக்கும் சுகர் பார்க்கலன்னு அர்த்தம். ரைட்டாக 3 கேட்டகரி. ஸோ நாட் நோன் டயபெட்டிக். இப்போ சுகர் 500 இருக்குது, அவங்க மாடர்ன் சைடில் வந்து டாக்டர் மருந்து கொடுத்து அதுக்குள்ள குறையவே இல்லைன்னு சொல்லி எம்எல்ஏ ப்ளேம் பண்ணுறாங்க அப்படின்னா, யாராவது ஒருத்தர் டக்குன்னு சொன்னீங்களா ப்ரைஸ் இருக்குது உங்களுக்கு, என்னது டயக்னோசிஸ்? தட் இஸ் கால் ஹீமோக்ரோமோட்டோசிஸ். டயபெட்டிஸ் கால் பிரான்ஸ் டயபெட்டிஸ். ஓகே, இப்படி ஒரு ஆன்செட்டில் வரும்போது நம்ம மாட்டிப்போம், இடையே சம்மந்தமே இல்லாமல் போய் எழுந்து நின்று நம்மளே சிலுவர் அரைஞ்சிப்போம். We should know what is hemochromatosis, not to treat, at least to save ourselves. இதை பற்றி ரொம்பலாம் பேசுவோன்னா, ஆல்ரெடி லஞ்ச் டைம் ஆச்சு, எல்லோரும் பசியில் இருப்பீங்க. இதை பற்றி இருக்கிற விஷயங்கள், நிறைய கேட்ட விஷயங்கள் கேஸ் ஸ்டடிஸில் வரும். ஃபஸ்ட் செஷன் உங்களுக்கு ஒரு பெரிய 2 ஃபீஸ் வெயிட்டிங். ஒன்று ரியல் ஃபீஸ்ட்டு, ஒன்று வெயிட் இருக்குது. அடுத்து செவிக்கு டாக்டர் சங்கர் இஸ் வெயிட்டிங். லஞ்ச் பிரேக்.
Shall we conclude this session? Any more questions? So